Sally. We appreciate your introduction, and yeah, really sorry that Kathy is not able to be here today. She had some family emergencies come up that she needed to attend to. So I will actually be pretending to do my best to cover some of the stuff with OT. But the good thing is Kathy and I have worked together for years, so I feel okay to do that. So what we're going to be doing today is kind of going through a couple of different things that we felt like were priorities when talking about feeding. And we have some slides to go through with you, and then we'll do a case presentation that is actually a case that Kathy and I started seeing several years ago. And I'm actually very curious to have the patient's dad on here today because I know Kathy has since been working with a speech language pathologist after he kind of graduated from our co-treats. So I'm very excited to see and hear how he's doing. So we'll go ahead and get started. And Hannah, if you don't mind, you can kind of flip through for us. All right, so these are the objectives. So we're going to start out just by talking about some of the risk factors that are associated with autism and developmental disabilities as they relate to feeding problems. And I think most importantly for Len, what we're going to do is talk about how the roles of various members in an interdisciplinary or multidisciplinary team both overlap, and then also if there are unique things that each of those members do. And then we're going to talk a little bit more about some of the evidence-based strategies that are out there that are used to treat feeding problems.
So we'll go ahead and get started, and I want you all to humor me for a minute, close your eyes, think about a time that you, like a good memory that you have of a meal. So a lot of people, that's with their family. Think about what you see, what you hear, how you're feeling in that moment, who's sitting around you. I know for me, my family is very Italian, and everything we do is around food. If we're happy, if we're sad, there's always food. And I don't think that you can fully understand feeding and feeding problems without thinking about the emotional piece of what a meal is and what eating is. So a lot of that times that's socialization. Even think about, meeting up with your friends, for a casual coffee or lunch. It's very social. A lot of people, you think about people are enjoying themselves. I'm sure a lot of you thought about a time that was really positive, maybe a Thanksgiving meal or even a family dinner. There's a lot going on at meal times too. There's a lot of different foods. There are different textures, colors, think about all the senses, lots of smells, sounds, all kinds of things going on. Again, a lot of times we're celebrating something. Typically, we think about it in a very positive way.
And unfortunately, for many of our families, this is more what mealtime can look like, especially for our kids that have feeding difficulties. And you can see here by this picture, I think the best way that I would describe this is it's just stressful. And there's stress from the family side of things, or from the parent side of things, there's stress from the child's side of things as well. And I think that that's something that we really have to take into account, especially when we see our families come in for feeding evaluations, just the amount of stress that they are under, because usually by the time they get to us, things are a problem. And so these things are really magnified by the time that we see them. And what we hope to do today is talk about how it might not seem like a lot of disciplines maybe are directly involved in feeding, but I think once you start to understand many of the different aspects of feeding that we look at, I think it'll start to make sense of how we all can kind of work together to work on these types of feeding difficulties. And one of the things that we wanted to cover on the next slide are just some of the characteristics that might make mealtime really difficult. And I will say too that a lot of this is this can be for typically developing children as well. But what we'll talk about in just a little bit too is how specifically some of the characteristics of autism really contribute to feeding problems. So during meal times, there's a lot of smells that are coming at us. There's a lot of visual inputs with the food itself, as well as any of the things that we use to eat. The texture of the food can often be something that can be overwhelming. Temperature, we have some kids that prefer hot food versus cold food versus room temperature. And then just from what Hannah had mentioned too about the stimuli that's coming at us. So for most of us, meals are a pleasurable thing and a social activity, but for many of our kids that we know with developmental disabilities, that can actually be a trigger or a stressor for them. And then we also know that a lot of our kids don't have a lot of practice with chewing and swallowing actual foods. So this can make things just a lot of work when thinking about all it takes to have a successful meal. So when you think about the prevalence of feeding problems in autism, if you kind of step back and take a look at it, it's like, oh, no wonder why these kids have a lot of feeding problems, because there's a lot of factors that are associated with autism that contribute to these feeding problems as well. So some of the things that we think about are with their communication deficits, if they're not able to tell us what they like or what they don't like. As you all know from the conversations that we've had about autism, that a lot of our kids have restricted patterns of behavior and interest and activities. So they kind of get stuck in these routines and really need things to be the same. And if they are forced to change, they can be really resistant to that. A lot of our kids also have sensory sensitivities and some of the oral motor deficits. We'll talk about this with the different roles of the different team members. And then I think something that we often take for granted too, for a lot of our kids, they are not as motivated socially. And so to say to them, watch your friend and see what they're eating. Like our kids may not care about that as much. And so they might not be as motivated by that social piece and fitting in socially. And then the big piece that we're going to talk about from a treatment perspective is also from the standpoint of anxiety and how we treat feeding disorders actually as an anxiety disorder. So like I said before, with those social pieces, these are things that I think, unfortunately, we have heard families, kind of report to us once they get to us. These are all things that providers have said to them. And I think it's with the best of intentions that, sometimes folks that may not have a lot of expertise in autism or developmental disabilities, they may say these things. But we often hear from families that they're told, oh, if you just stop giving them what they want to eat, then they'll eventually eat what is offered to them. And that is just not the case with our population. We have kids that will literally go on hunger strikes where they will not eat anything unless their preferred foods are presented. So that unfortunately is not the case with our population. That it's something that they'll just be able to kind of be waited out, that they're not just being stubborn. A lot of our kids are stubborn, absolutely, but that is due to a lot of those characteristics that we talked about with autism that contribute to some of that stubbornness when it comes to feeding. And then I think the other one that we hear often is, oh, don't worry about it, he or she will grow out of it. And that's not the case with our population either. And in fact, oftentimes what we see is that feeding problems don't get better without intervention, they actually get worse over time. And so it's something that we have to be very mindful of when parents kind of report these concerns, that it's something that we have to take seriously, and know that without proper intervention, that it's likely that these will just become more ingrained over time. And I mentioned this before with kind of the social piece, that oftentimes we hear, well-meaning folks say, oh, once he gets to kindergarten, then he will want to eat what his friends are eating. And that's just not the case with our population. So now I'm going to pass it to Hannah, and she's going to talk more about when should parents kind of become concerned and when should they start to seek some more support.
Yeah, so a few reasons that parents should take that next step. So if they're worried that their child is not getting the right nutrition, so we think of calories, overall nutrition, if they're just completely refusing their food, or if there is that aggression piece, they're injuring themselves, or it's a huge hurdle that that is interrupting the rest of their day. So we look at two different areas of feeding problems. So the first one we have skills deficit. So this could be physically, it is difficult for them to eat. So their chewing pattern is not right. They can't get that suck pressure right. The swallowing is impaired. It's those physical aspects that are getting in the way of them eating. We also see the intake piece. So they physically can, but they're refusing, or they're very selective about the foods that they are eating. So those are the two different breakdowns there. And again, what Jen was talking about, so we have different professionals working in the skills deficit area, different professionals who are going to take that insufficient intake piece. So again here, so we have these different areas that could get in the way of feeding. So we have, again, like that physical, the medical issues, and then we have behavioral, which would be psychology there, and sensory occupational therapy would get involved.
All right, and I'm going to talk more about what multidisciplinary evaluation looks like for kids with feeding problems. And there's kind of an order to this that we wanted to present this in, because the first step in any evaluation would be to confirm the child's medical status, and to be able to rule out if there's any medical causes of feeding problems. And there's a really important reason for that. And that is, regardless of what we do from a behavioral perspective or from an OT perspective or an SLP perspective, none of those things are going to work and be effective if there is an underlying medical condition that is underlying the feeding problem. So any first step of feeding treatment has to be to rule out and make sure that the kids are cleared from a medical perspective in order to be able to participate in any type of feeding treatment. And then as you see these other disciplines becoming involved, these don't necessarily have to be like in any particular order. So it might be based on kind of what the main kind of presenting concern is, but these are the different players that would be involved in a multidisciplinary evaluation. So we would have somebody from nutrition to be able to look at overall nutritional status. And we would also look at from more of the physical standpoint with their with the kids' motor abilities and physical abilities. And Hannah is going to talk a little bit more about this as well, from kind of the physical oral motor piece. And then also from the occupational therapy side of things, evaluating for sensory concerns, knowing that if a child has a lot of sensory sensitivities outside of meal times, it's likely that they're going to have sensory sensitivities to meals and to foods as well. And then I'll spend some more time talking about behavior around feeding and how we do that. And that's where psychology and behavior analysis kind of comes into play with our evaluations. So when we Think about like the medical contributors to feeding problems. There's a lot of different things that we have to do to say, okay, are these the things that are contributing to feeding problems right now? So we do a pretty full evaluation looking at whether the kids currently have some of these concerns or by history, because feeding, like we've talked about, is kind of something that kind of evolves over time. So one of the things that we look for is any type of reflux, knowing that that can have a significant impact on feeding, any type of other intestinal diagnoses, food allergies or intolerances is one that some can contribute, aspiration or choking, or any type of injury to kind of the oral motor or more from the structural standpoint. Hannah is going to talk a little bit more about dysphagia and some of the motor planning issues. But these are all types of things that we would be doing like in our initial evaluation when we're looking at any of the medical causes of feeding problems. And then if we think that a feeding problem is due to medical concerns, then we would, and I should say, when I say we, I'm talking about kind of our team. And so oftentimes in DDBP, for example, a family will come in and they will meet with a developmental and behavioral pediatrician. And if there's feeding concerns, then the developmental pediatrician will make a referral for feeding. And then from our standpoint, then we decide, okay, are there additional referrals that need to be made in order to rule out any of the GI issues? Is there a need for an allergist to check out food allergies? Is there concern regarding growth, and that they need to be seen by endocrine? And then for speech therapy evaluation, which Hannah will talk about in just a second. So I'll pass it to you, Hannah.
So for the speech therapy role, so we're going to look at more of that physical, it's physically difficult to be eating. So I'm going to walk you through what that would look like. So if we get a referral to speech therapy for feeding, we're going to start with our evaluation. So our goal is figuring out, why is this child having difficulty eating and swallowing, and where. So we want to trace the food material from when they put it in their mouth and see where it's going when they're swallowing. So ideally, we want it to go in their mouth, down their throat, to their stomach. That's not always the case. So they may put it in their mouth, and as they swallow, it may go, for example, to their lungs, which is called aspiration. So that's what, it's going to make them choke, cough. And if it goes into their lungs, then that could develop pneumonia. So that is not good. But that happens. It's pretty common when we see these feeding difficulties, is that they're aspirating or that food material is not going where it needs to be. So we're going to trace that food material to see if it's going where it needs to go and where the breakdown is in that swallowing process. So we're going to do an instrumental assessment. So we can have a few different ways to look at that. So MBS, modified barium swallow, or a video X-ray is what I like to call it. It's a video of someone taking a drink, and you can actually see that video of where it's going in the body. Another assessment we can do is called a FEES, and that's having a direct view of the swallowing structures and where that material is going. So here is a picture here, a diagram. So let me see if I can get my red light. Okay. So we have this green, I don't know what to call it, the green material there. So that's the food. That's going to symbolize the food here. So we, in a perfect situation, it would be like on the left, it's going to go straight down here, and it's going to go to the stomach. Now, if we look on the right, if the food is swallowed and it's going down the throat here, it could take a detour to the left and go down the trachea and go to the lungs. So that's not what we want. So that's what I mean when I say we're going to trace it. We're going to see where it's going in the body. Oops. Oh, there we go. Okay. So there are a few things from a speech pathology standpoint that we can do if there is a problem that's identified. So I'm going to talk about 3 today. So we have swallowing strategies, we have oral motor exercises, and texture modifications. So the swallowing strategies, the way I like to think about this is that you are capitalizing on the strong aspects of your swallow. So this is a compensatory strategy. So if we think about our tongue, the way that our tongue, it's very powerful in our swallow. So our tongue, when we swallow, should be pushing on that back wall of our throat. But if it's not, for some reason, that's going to affect the way that our food is moving down. So if you tuck your chin like this, when you swallow, you're helping your tongue push back on that back wall of your throat. So that's one way, if we see this is where the swallowing breakdown is happening, we could use a strategy like that to just manipulate your body movement a little bit to get that food to where it needs to be. Something else we can do are oral motor exercises. So this is strengthening the weakened muscles involved in the swallow, if that's applicable. So I like to think about this like lifting weights. So you would go to the gym and lift weights for your biceps to make those muscles strong. So same thing here. There's so many muscles involved in swallowing. So for example, you have your muscle here that runs like in a circle around your lips. If that muscle is weakened and I take a drink of water, I may have water dribbling out of my mouth. That's not good, right? That means it's not getting to my body. So if we want to work on that muscle, you can make like a kissy face and push out. So I want everyone to try that. So make your kissy face and push out. So it's just a small little strengthening exercise there, but we can do it just like I said, just like you would lift weights. So, 3 sets of 10, whatever it is, you can strengthen those muscles to increase your swallow. Something else, I think that this one's super fun to talk about is we can do texture modifications. So I have a little demo here. I hope that everyone can see it. I'm gonna move my camera on. So I have water. Oops, I need to get more water here. Okay, we have water in this spoon. This one may be difficult to see. And I have pudding in this spoon. So I'm going to flip these spoons over, and I want everyone to look at the speed at which they're falling. So which one is going faster, which one is going slower. So we have water here, pudding here. Okay, I'm gonna flip them. Okay, so someone can come up and mute, which one fell faster?
The water.
Yeah, good. Yeah, so water fell faster and the pudding was slower. So let's build on that concept. So it's the same way when you go to drink. So we'll first talk about drinks, then we'll move to food. So when you go to drink, if you're drinking regular water, we call that thin liquid, that's going to move faster, for example, than if you eat a spoonful of pudding. So that is the whole premise behind thickening your liquids. So you can, if you make your liquids thicker, it's going to move slower down your body, and that's going to give you more time for your muscles to react. And it's going to help you control that bolus or that food ball as you move it down your throat. Super interesting. So I'll give you a high level overview. You don't have to know all the details of this, but this is a standardization that we have when we think about thickening our liquids or modifying our solid food textures. So first, let's look at the right section. I think it's easier to talk about it with liquids first, and then we'll move to foods. So we have a whole spectrum of thickness for our liquids. So we start down here with thin liquid. That's just regular water, apple juice, coffee, wine, anything that you think of as just a normal drink, that's thin liquid. And then on the other end of the spectrum, we have pudding thick or extremely thick. So that's that chocolate pudding I just had. So the thinnest you can have, the least restrictive, is thin water, just regular water. And the thickest you can have is pudding. So we can recommend a thicker liquid for someone if they're having a hard time drinking water, if they're choking on it. But there are all these steps before that too. So I actually have some mildly thick, which is here, that this pink one here. This is thick water. It's very funny to drink the first time because you're not used to drinking thick water. But it's just thicker than normal water. But you can add thickener to any drink to make it a different thickness. That's what we have here in our liquids. And when we move to our foods here on the left, it's the same concept. So we start with regular at the top here. So that's the most difficult to chew and swallow. So think about like potato chips, really crunchy. To eat potato chips, you have to have this nice circular pattern of chewing. And when you're swallowing it, it's not necessarily staying together in that nice food bolus or that food ball. On the other end of the spectrum for foods, we have, think about like mashed potatoes. So that would be down here for pureed foods. That's much easier to eat. And then again, we have all these stair steps in between potato chips and mashed potatoes. We have some few steps in between there. So ultimately, what I want you to know from this chart here is that we can recommend a safer diet. And just, you know, again, it's not necessarily diet like we think of, but a safer texture for people to eat if they're having a hard time drinking regular water or eating those crunchier foods. I want to stop there. Does anyone have questions? I know that lots of diagrams here. Does anyone have any questions about the different textures before we move on? Okay. So now I want to put this into context when we think about infants and kids. So we can do this thickening of liquids and texture modification for infants and kids as well. So if they're under 12 months old, you can use baby cereal to thicken the liquids. So you have to do this with formula because breast milk can actually break down that cereal and then it won't be thick anymore. So you can grind up the baby cereal and mix it in with the formula to make it thicker. And you add a different amount depending on the thickness that you need. And then over 12 months old, you can do natural thickeners or artificial thickeners. So we'll give you an example of each of those. So a natural thickener would be if you want to give your kid juice, let's say apple juice, and you mix that with blended fruit. So that's going to make it thicker than just if they drink regular apple juice. And then an artificial thickener is what I have here. Now, it's a little bit hard to see, but so this is water, but it's thick water. So this is, when we think about those artificial thickeners, that's like adding some starch to it, but it's something that's pre-mixed. You can, use a pump to add that to different liquids and change the thickness there. So again, we want to think about the nutrition when it comes to these kiddos. So are they gaining the right amount of weight based on growth charts? Are their hair, are their nails growing? All those things. Are their clothes just not fitting the same anymore? Are they way too big? So we want to make sure that these kids are getting the right nutrients. Because if they're not, they're getting, poor nutrition, lots of effects can happen. So their brain isn't growing the way that it should be. They're not getting as tall as they need to be. Their wounds are not healing. Their bones are not developing. That is so important when we think about the health of our kids, especially long term. So we want to make sure that they're getting those right nutrients. Now we'll pass it over to Jen for her portion.
Thanks, Hannah. So Hannah talked about more of the kind of structural aspects, and the way that we would think about that is those are the kids that have more difficulty with the can't do kind of side of things. So it's more challenging for them to do those things because of some of the structural and some of the oral motor. What I'm going to talk about more is from the behavioral side of things, and these are more of the won't do type of kids, where they might have okay structurally, but they are really struggling from a behavioral standpoint. And that oftentimes these behaviors get reinforced over time. And so if you've ever been in the situation of feeding a little kiddo and everything is going along great, usually adults, we don't attend a lot to that. We'll just kind of do our thing. We'll keep on going. We'll keep presenting the food. The minute that things go south is when we start to pay a lot of attention to kids. And so oftentimes during meals, those inappropriate behaviors get reinforced over time and cause more difficulty. And we tend to not pay as much attention to the behaviors that we want to see more of. And so one classic example of this, I think, is one of the things that is like a pet peeve for me is the good old like airplane game, like where you're trying to like convince the kid to take a bite, and then the more that they resist and the more that they refuse, the bigger our show becomes, and we have to put on like a whole performance in order to get them to take a bite. So a lot of our job from a psychology and behavioral standpoint is to kind of change that pattern of behavior, not just for the parents, but as it relates to the child as well. So these are just a list of some of the disruptive behaviors that we look at during mealtime. And you can see here that they vary in kind of intensity from the standpoint of just some minor kind of screaming and crying, having tantrums. Leaving the table, I think, is a classic kind of avoidance maneuver. And then we do have some kids that have more significant behaviors during mealtime that could look like aggression towards other people, towards their feeder, self-injurious behavior towards themselves, and then just some disruptive behaviors that involve, either swatting the food or knocking the food off the table. And then some of the things that get tricky for us and trying to figure out, is it something that is a physical cause or is it a behavioral cause that needs to be treated, is with spitting out food or with vomiting. So I'll talk a little bit more about kind of this in just a little bit, but these are just kind of some of the behaviors that as we do feeding assessments, we're kind of taking an account of how many times each of these types of behaviors happen. So one of the things that we really try to teach families coming in is that we really need to find a way to reinforce the appropriate mealtime behavior and to catch our kids being good, and as much as we can to be able to ignore this inappropriate mealtime behavior. This becomes really, really challenging because there is something in our field, and I think Megan probably talked about it when she did her ABA talk, but we have to be aware of something called the extinction burst, knowing that things will get worse before they get better. And our kids have learned, okay, if they are not getting a reaction for something that they used to get, then they're going to up the ante and they're going to increase their behavior in order to try to get a response. So we've had kids that have come in and they will go through this whole cycle of behavior that may start with just simple kind of refusal or like a negative, like vocal protest, and then end at the point of them like I've had kids like stripped down naked during meal times to try to get attention, from the families. So obviously this is something that becomes really hard to manage, and we have to be able to choose the type of intervention that we're going to do based on what we know that the family can handle. Because a lot of this type of stuff, the family is not going to be able to have this as a functioning mealtime during their family meal at home when they have other kids that they are feeding as well. So the behavior management becomes kind of like an art and a science as we work with families to try to figure out like the best interventions that we're going to have. One of the things I want to spend a lot of time on is talking about the role of anxiety in feeding, and this is how we treat feeding disorders within our division is basically as an anxiety disorder. Knowing that a lot of kids who come in who have feeding problems have a lot of anxiety, not just around food, but around a lot of other things, and that food just becomes a part of that. But one of the things that we also see is that this can become conditioned over time. And so an example of this is if you have ever had too much of your favorite alcoholic beverage and you have gotten sick off of said alcoholic beverage, that alcoholic beverage probably does not sound very good to you the next time it's presented to you. Same thing with our kids. So sometimes there's this thing that happens where they might have this conditioned aversion where they ate something and something made them sick and now they are afraid. So think about that with food allergies, for example. So a lot of our kids who have food allergies, it's adaptive for them to be thinking about, oh, is that food going to bother me? Is it going to hurt me and make me feel bad? So that increases kind of that anxiety. The other thing with our kids, especially with autism, is that they become really rule governed and they decide, okay, I'm only going to eat things that are round, and I'm only going to eat things that are orange, and I'm only going to eat things that are presented one at a time, on my plate. And then they become very, very upset when those rules are broken. But the biggest thing that we see with a lot of our kids is that the picky eating is just a fear of new things. And the fancy term for that is neophobia. So that's the fear of anything new. And that's where the fear of new food comes into play, where just like we would treat any other type of phobia, it takes that gradual exposure to get over the fear. And so we're going to spend some time talking about kind of what this looks like. So when we have these kids that come in and they have these have this anxiety, have these fear of new things, they are doing anything in their control to gain control of the situation. And then that is actually going to increase the parent's anxiety. And as a result of that parent anxiety, parents get desperate and they start to kind of do whatever it takes in order to get their kids to eat. And so it becomes kind of unpredictable, where they try a bunch of different things, but lose the consistency of being able to actually work on the phobia, because with that inconsistency, we actually increase the kids' anxiety. So it becomes this whole cycle that we have to kind of break. So as kids come in for our feeding clinic, what we're trying to do is work on the child's anxiety, but then also the parent's anxiety, and give both of them more control in ways that are adaptive for both the child and the family. And so we'll talk about a couple of ways to do this. So when thinking about kind of the overall approach that we take to treat feeding, we use strategies that are based on principles of ABA that you have learned about throughout the semester, and also through the awesome presentation with Megan, that we have years and years and years of data that show that feeding problems can be treated successfully using principles of ABA. And we look at it just like we would any type of other type of behavior. So we focus on changing the eating behaviors. So instead of refusing, we want the kids to accept. Instead of gagging, we want the kids to swallow. And instead of having any other type of disruptions, we want them to be compliant with meal times. So one of the things that becomes tricky, I think, in our particular field is that parents come to us And these problems have developed over time and have gotten more ingrained and have gotten worse. And unfortunately, from a treatment standpoint, it's going to take that amount of time to kind of unwind and to unravel some of that behavior that has become so ingrained. So that, I think, is really frustrating from the standpoint of a family, is they come in and there's not a quick fix for this, just like there's not a quick fix for any of the other types of behaviors that we work on. So it's something that I think we as providers really have to walk that journey with the family to say, okay, we know this is going to be a long road and we're here with you. And we also know that things might get worse before they get better. And I think that's one of the biggest things I've learned over time, is how to have that conversation with families, to be able to say, I get that you're in this right now. This is your family. This is your one experience, where I have hundreds of other examples of getting to the other side. So being able to build that trust with families, I think, is key to be able to recognize kind of the peaks and valleys that our families go through when they're doing these types of interventions. So the main way that we go about doing feeding therapy within our division is through gradual exposure. So if you take yourselves back to kind of the Psych 101 days, where you learned about systematic desensitization, of being able to gradually get over something that you are afraid of. So you have a hierarchy that you build up to be able to say, okay, this is kind of the hardest thing, and then there's all of these other steps in between that we need to practice in order to get there. So we actually set up our feeding sessions as eating practice, for a couple of reasons. One is that you're able to structure it a little bit more, and you're also able to separate out from meal times and not make meal times even more stressful than what they already are for the families. So I'll talk through what a typical kind of eating practice looks like when we think about like this systematic desensitization. So this is an example of a hierarchy that we may set up. And again, every kid is going to be different depending on their level of refusal and their level of just how difficult their acceptance or tolerance is of food. So for example, some kids might not even be able to tolerate being in the same room as somebody eating a food that they don't like. And so for those kids, we would have to start there. And then we would have, somebody eating that target food, then we would introduce it to our particular patient. And it might start as simple as having the food on the plate next to the child's own plate before ever getting it to their actual plate. And then we move through a certain hierarchy of feeding kind of exposure steps. So first step is, and for some kids, it actually might be that we smell the food first before they are ever expected to touch it or before they're ever expected to pick it up. And then we move it to touching their lips, then touching their tongue before ever expecting a small bite of the food. And then being able to increase that size and that amount of food over time. Where I think we mess up a lot in feeding is that sometimes we try too many things at once. So we try too many foods at once. So if you think about what I mentioned with that neophobia, of fear of new things. If we are consistently introducing new foods, we're not letting the kids get over that phobia, get over that fear of that new food. So it's really important for us that we start with one food, get successful with that before moving on to another food. Because if we don't do that, then the kids' anxiety is just going to increase over time. So that is an example of how we would kind of set this up. As we do these types of hierarchies, there are things that we have to consider that are listed on the next slide, that we have to make sure that each step in that hierarchy is really manageable, because we have to make sure that we're not taking too big of leaps in between the steps, because that's just going to set the kids up to be unsuccessful. So we can't expect a kid to a kid who is not willing to touch a food, that kid is definitely not going to be willing to take a bite of the food. So we have to make each step in between manageable. We also have to make sure that the foods that we pick are going to be successful, and they're going to be something that fits kind of within the current limits of what the child is eating. So I think this is a pitfall sometimes when we have families come in and they want their kids immediately to work on vegetables. And I'm like, we have a gazillion steps in between before we work on any type of vegetable. Let's start, with something else. Then I mentioned working on one food at a time. Another thing that I am, and I think all of us who do feeding are very adamant about, is making sure that the kids know what the plan is and to be able to follow through with the expectation, and that we are not sneaking food, because that, from a trust perspective and an anxiety perspective, is just going to amp up that anxiety a lot more. So, there's a couple of cookbooks out there about sneaking, vegetables into foods and that sort of thing. And then as soon as the kids learn that, they're like, you just pulled a fast one over me. I'm not going to trust anything else that you put in front of me. And so it's really important that the kids are very aware of what is being presented, and that they understand and can build that trust over time with whoever is the provider. And then to reinforce each step before moving on, because I think this is something that also families get excited and they're like, oh, like they were really successful. We're just going to try this and see what happens. And then when parents do that and are kind of unpredictable, then that anxiety from the kid increases even more. So I know I went through a ton of stuff from kind of an exposure standpoint. I want to stop there to see what questions folks have before moving on to more of like the sensory pieces.
Do you have families that are discouraged when you kind of say like, hey, we have a lot of steps in between that and maybe your goals? Do you have families that maybe get bogged down by that or are discouraged and don't want to go through all of those steps?
For sure. Yeah. And a part of it is being able to, I think, have those honest discussions of like, yes, we're going to get there, but in order to get there, we have to do this to be successful. And kind of that conversation of, you have tried this, you've tried all of these strategies and none of them have worked so far. Stick with me, like for a little bit, and let's get some progress. And then usually we can get some buy-in, because oftentimes we have to change the narrative for the family to recognize that any new food is like a huge win. So even if it is a different kind of chicken nugget, like that is something new, you know, for that kid. And so I think that's a very, that's a hard conversation, and one that I think I've gotten better over time having with families. But being able to recognize that, yeah, that like this is their end goal, but how do we get there is going to look different than I think what they expected. Yeah, good question, Angel. Any other questions? Okay, we'll move on to the sensory. And again, this, I'm just going to channel my best Kathy Krebs. After working with her for as many years as I have learned a lot, you know, when it comes to these sensory sensitivities, because I think we are looking at things from a similar perspective, in that it all comes down to anxiety, and that the kids are anxious because maybe they don't know what those sensory aspects are going to be like for the food. So maybe they don't know what it's going to feel like. Maybe they don't know what it's going to taste like. And so part of it is helping kids understand about the properties of food, so that way their comfort with taking a bite will increase. So being able to talk about, what does the food smell like? What does it taste like? What does it remind you of? Is it crunchy? Is it soft? Any of those things that you can ask yourself, what is it that I can do to help this child feel more comfortable taking a bite of the new food? So it's that whole idea of like, that knowledge is power, where if they have more knowledge about all of these different properties, that is going to decrease their anxiety and increase their tolerance to be able to try some of these new foods. So from a sensory standpoint of how we approach things, there's a variety of different approaches for feeding sensitivities, but there's not really one that is specific just for ASD. So I think it's similar to a lot of things that we've talked about, where we've learned over time what works for our kids and like what works for our population, and how we can draw from different things. Where we want to teach sensory exploration of food. And this is where I'm trying to channel my best Kathy Krebs. We don't get stuck playing with food, because playing with food implies that food is to be played with, when our intent is to teach the kids that food is to be eaten. And so if you're just getting stuck with playing with food with no intention of building up to taking a bite of the food, then that's not teaching the kids the right thing. And so it's really, really easy for our kids, especially, to learn, okay, they give me this food, all I have to do is play with it, and that's the expectation. So being able to teach those properties that you can do through play or exploration in order to get that comfort built up for the kids, that once they're able to move past that anxiety of, again, kind of pulling a fast one on them and not having kind of clear expectations. So being able to teach them how to understand those properties and make it easier for them to accept those foods. And then also to keep it fun. This is like a number one thing that I've learned from Kathy, where I think our approach in psychology is more parent driven, and parent guided, where we're teaching the parent, and we are setting the expectations. With occupational therapy, it seems, and Kelly, I might tap you for this as well. It seems like with OT that a lot of times it's more child driven, and oftentimes families will be more willing to do OT first before doing psychology, because it seems to be like less stressful for kids to do these types of approaches before having like the clear expectations of like the parents like being more in control. Kelly, I don't know if you have anything to
Yeah,
say
I
about
feel
that.
like a lot of times when I do feeding, it's like me first kind of showing them what to do and then slowly bringing the parents in like one at a time and not trying to overwhelm them with like, do this, this, and this at home. I
Yeah.
also feel like we try to hit like mealtime structure a lot as well, of like maybe trying different adaptations before like forcing food or anything like that as well.
Totally. Yeah. Thanks, Kelly. Another thing that we have to kind of think about too is are the kids, we get this a lot too, where the kids will get really satiated on drinking or snacking throughout the day. So we get a ton of kids where we'll do like the interview and we'll ask, you know, like how many ounces of milk, you know, does your child get throughout the day, or how many ounces of juice? And it's this astronomical number. And you're like, well, there's a reason why your kid's not accepting, you know, foods, because they're not hungry at all, because they are satiated, you know, from what they're drinking. And so this is another way where we try to, like Kelly was saying, set up that structured routine and with a schedule so the families can start to teach their kids what it feels like to be hungry and what that feels like, you know, to be hungry and then to get food and to have that kind of need met. Oh, yeah. Yeah. So, Kelly, parents say over 64 ounces of milk a day for a 2-year-old. Yeah. So you'll hear that. You'll hear, you know, like I've had families say, yeah, they'll eat a like a family size, you know, bag of Doritos across the day. So I think really helping that structure really makes a difference. And then the next thing that we're going to talk about is with food chaining. And there's a great book that is called Food Chaining that talks about how families can set up foods that are familiar to the foods that are accepted already. So similar to what we talked about, we're not going to get kids to eating vegetables immediately. We have to find those foods in between. And so it could be that we're starting to have slight variations on the preferred foods. It could be that we're doing different flavors or different brands. I know Kathy does a really good job of talking about like the different properties of food. And on the next slide, there's an actual food chain that we use kind of as an example, that we get a lot of kids, a lot of families that come in, and the poor families are driving to McDonald's multiple times per day because it's the only chicken nugget that their kids will eat. And so oftentimes we will work on that, where we have to think about, okay, we're not going to get this kid to go from a McDonald's chicken nugget to grilled chicken immediately. There's going to be these steps in between. So maybe we start with a different restaurant, and then maybe we move to doing like a frozen nugget at home, and then we move to something that is more like chicken. I know we talk about this a lot, that we will you know, talk about adding in like Chick-fil-A because it's like actual chicken. And so that seems to be like a gateway to a lot of things that can help us, you know, kind of bridge that gap. And so these are just examples of, you know, one way that you can do food chaining that could be successful. And then there's a couple of things that we have to think about, like with food chaining, too, is, you know, we have to be able to involve the kid as much as possible. So this is going to depend obviously on like functioning level of the child and a lot of different factors behaviorally. But the more that you can help the kids gain control in whatever way possible, that they are able to pick, what it is that they do like now and what they might be willing to work on, and then being able to offer choices. Kathy has taught me so much about that just right challenge of making sure that we are pushing the kids far enough that they're making progress, but not too far that we blow it. And so I think that kids can be really good if we sit back and listen and watch. And I think also being able to help the kids talk about food in a different way, because oftentimes the verbal extent of their talking about food is either they like it or they don't like it. And so how can we expand to talk about, those properties of food again, that they again start to have a little more control over, what they are learning about the food. There's a couple of things to keep in mind with food chaining where I think we get a little stuck sometimes, is that we might lose the forest for the trees, where we have to really think about what it is our goal, where if we don't introduce things, and we stick to like just that food chaining, then we could lose out on an opportunity. So again, it's kind of that just right, where our structure is to set this up in a structured format, increase the control, decrease the anxiety, but then like put out some stretch kind of goals too, to just see, kind of where the kids are at, because what we see is that this gets easier for kids over time. So the more that you do this, the more trust they have, and you might be able to get from one to another. So the example here that Kathy said is that they did not chain from Pop-Tart to peas, because there's no way to do that. So, but being able to have it structured, but then not get too stuck in that, and being able to kind of remain flexible as you go through. All right. Just wanted to talk about a few of the visual supports that we use in treatment that tend to be pretty successful. So Social Story by Carol Gray, I oftentimes will like refer to the ones that I do as social narratives, so we don't upset Carol Gray, because social stories have to be very structured and follow a certain format. So oftentimes I can do that where it's describing kind of what we're expecting of the kids with trying a new food, that it's okay to be anxious. Here's the things that you can do if you start to feel anxious. And then we also have, for some of the older kids who are starting to understand, just kind of health and nutrition, and maybe are learning about that in school, reasons that we eat new foods and drink new drinks, and to help them understand that nutritional side of things. Rules, this is where a lot of our kids with autism tend to be rule oriented, and we use that to our advantage as much as we can. We do a lot of countdowns with bites. So literally a 1 to 10 board, visuals of steps. I think we have a couple of examples on the next slide, maybe. Yeah, so here's some examples of some of the visual supports. So in this one to the left, these are the different steps of exposure. And so we will set it up where the kids have an expectation to touch, the food, and then we'll use this visual countdown board to say, okay, we're going to do 5 touches. And do you want to do 6 or 7 smells? And so kind of, again, giving the kids control, making those choices. And then these are just examples of some of the like file folder types of activities that we have that can help kind of expose kids, especially in Kathy's like OT therapy, of being able to, again, kind of learn about those properties of the different food. That tends to be really, really helpful. Okay. And I've kind of talked about some of these things as we've been going along, but I think number one, building trust with the kids where they know that you are doing this with them, that you are not going to pull a fast one over them, and you're not trying to trick them in any way. Being able to pull in things that can be fun, talking about the kid or talking about the food, and so they can learn. I think offering offering choices, but not yes, no. Like, do you want to try blah, blah? Nope. We get a lot of that. So being able to frame our questions in a way. And then also, if something is too hard for them, to be able to recognize that and to say, you know, that's too hard today. And recognizing that days, even times of day, are different. So a kid could be successful in the morning, you know, with a particular food, and then later that afternoon have a harder time with it. And that is just all related to a lot of things that we've learned about autism and developmental disabilities, with just the conditions and the expectations and generalization. And I love this. This is like another nugget from Kathy that I've learned, that approach it from the standpoint of like, what is it that the kiddo is going to do today versus what I want the kid to do today. And that like has kind of changed perspective, because I think sometimes as behavior analysts and psychologists, we get stuck in this, no, like this is the expectation, this is what they're going to do, and it just sets the kids up for failure if we're not able to adjust to that. So that's something that I've definitely kind of learned from our OT friends. And yeah, I think just being able to ask some of these questions that are on the next slide can be really helpful, because, you know, you have to think about, okay, what is different about this week? Because maybe they were successful last week and they took a bite, but this week they're not having it. So how can we make it successful in some way? And is it okay to change those expectations if it's still kind of moving you forward? Kind of thinking about like the progress that we make in therapy is not always linear in the way that we think that it should be, that sometimes we have to take some steps back in order to not get into that like power struggle that our kids can get into pretty quickly. All right, and just a few more things, and then I'm going to pass it to Hannah. One of the things that I think is really important, and this goes back to what Angel was saying, being able to set priorities for the intervention and being able to come up with consensus on that of what is important. So if you see a child who the caregivers have one idea for treatments, but you have a different idea, how can you get to that place with shared decision making where you can find what you're going to work on together, and also being able to not control that too much. So for example, I had a dad who during our first appointment, he was like, my main goal is I really want to sit and eat nachos with my son on Super Bowl Sunday. And I was like, you got it. That that's going to be our goal. Like, I think that's amazing. And from a social standpoint, and so like it might take some adjustments on our part. Same thing with, I've had families say, all I want is for my kid to eat birthday cake. Like, they have never eaten birthday cake on their birthday. Like, please help my child eat birthday cake. So these things that, may not seem like a priority for us are huge for our families, and being able to set those expectations and those priorities around intervention is key. Hannah?
So from going back to the nutrition standpoint of things, so this is ideal. So breaking up the plate into fruits, grains, vegetables, protein, you have some dairy as a drink. So this is ideal to get some different nutrients, but of course we know that this is not always realistic. Even in my household, for me, this is not even realistic every day. So we want to remember that when we're giving recommendations to families, that it's not always going to be that textbook picture that, maybe we would hope for, and that's okay. And this is funny. You're an autism parent when your child eats a new food and you Facebook it, call your friends, and text your friends to celebrate. So some conclusions here. So the kids that we work with, kids with DD, they're prone to feeding problems for so many different reasons. And those problems can be learned behaviors or sensory sensitivities. And it's our job to figure out where is the breakdown in feeding and what professionals can work to help those problems. And a lot of times it's a mix of a bunch of different professionals and a lot of different problems. So we're going to figure out where that breakdown is.
Sorry, Hannah, I couldn't find my mute. Yeah, so just to go back to kind of the big picture, we know that these problems don't develop overnight, and they're not going to be treated overnight. And that, I think, is a conversation that is a necessary, aspect of treatment, to be able to have that conversation with families. But we do know that there is hope. And I think that that's the other piece, that's the word that we keep going back to often. From diagnostics, and when a kid receives a diagnosis, or if you figure out like a treatment plan, that there are behavioral strategies that are effective, and we have loads and loads of data. I just have to share this real quick. James, you'll appreciate this because Allie Fisher. So Allie Fisher, who was a Lynn trainee last year, her mom, Kathleen Piazza, is like the person in feeding, like the person. And so I was so anxious last year because I was giving this talk to Kathleen Piazza's daughter. And so I had to text Allie and was like, Allie, like, this seems so silly to me. I am like fangirling about your mom. So anyway, we know a lot, I bring this back, but we know a lot of these strategies are successful because of the research that is done by folks in our field. And so we know that, there is successful strategies that we can use, but often they require multidisciplinary evaluation as well as interventions, which I think our case will tie in nicely to this as well. And we have some, I think, resources on here as well. Oh, yeah, we wanted to talk about, the feeding treatment within DDBP and kind of the process for that. So a referral is typically made by a developmental pediatrician, and that is for an initial feeding TPS that happens with an occupational therapist and a psychologist at the same time. And from that appointment, we decide what service line is most appropriate. So if psychology is determined to be the right next path, then we send them to the psychology wait list for feeding. If OT is the right path, we will if they are already in OT, I think Kathy does a really nice job of consulting with the current provider to see if there's things that she can help with. And then we also have something called brief intensive feeding treatment, BIFT, that is a combination of psychology and OT. And so the first session is with an OT and a psychologist. And then the second session in the week is psychology and it's over telehealth to see how things are going within the home setting. So those are for kids that need both types of treatment, OT and psychology at the same time, and also a little more intensive. So that's kind of the range of feeding treatment that we have in DDBP, and then some resources for you all. My favorite is a book called Broccoli Boot Camp. It's one of those books where I'm like, oh, I wish I would have written that. Like, it's really good, and it's a really good descriptor of what we do in our treatment sessions, and then a couple of other great resources as well. So we have a few minutes before our patient's dad gets here. So we'll pause for a second. Let's see what questions folks have, and then I'm gonna set up our case a little bit. And Hannah, the slides that I sent you earlier should have the case material on it.
Okay, yeah, let me pull that up.
Okay, Kim.
Hi, I just had a general question. So
Yeah.
I know you said at the very end that you do brief intensives with psych and OT, but I know from a motor perspective and physical therapy and occupational therapy, we normally do that like episodic care. So I didn't know if that ever comes into play with feeding. Like this session, we're just going to be working on improving interest in fruit, and then like take a break, and then you do another episode of like improving different types of proteins. I was just curious, like long term, are you guys doing treatment then break, or how does that work?
Yeah, yes, we do now. It has evolved over time. I think just from an access standpoint, where that's definitely like how we frame things now, is with more episodes of care. Typically the way we set it up is like we'll have very identified goals with the family. We'll see how they make progress with those goals. Then we'll take a break, see if they're able to maintain those things at home, and then we'll reinitiate. Yeah.
Thanks.
Yeah, you're welcome. Hey, Mark.
Hey, Jen, I am not seeing the case in the slides. Do you mind sharing your screen for this?
Oh, sure. Yeah.
Can you hear me?
Yes.
Yeah, we can hear you, Mark. It's good to see you.
Oh, thanks. Thanks for having me.
I'm so excited because I was telling this group that, I worked with you all, and then you all kind of graduated from psychology, and then you're seeing some other providers. So I'm excited to get the update. So I just have a few slides, Mark, that I put together just based on Ryland's kind of information. And then we'll kind of pass it to you to hear how things are going. Does that sound like a good plan?
Yeah, sounds great.
Okay, perfect. Okay, are you all able to see this? All right, so I am going to be presenting on one of my favorite kids that I've ever worked with. He is so precious. I love him so much. His name is Rylan, and he was actually referred by the team at the Thomas Center after he had a surgery and he stopped drinking liquids. So he was 3.5 at the time of the referral, diagnosis of Down syndrome, and some pertinent medical information that ties into this as well. He has frequent respiratory illnesses, nasal obstruction, reflux, constipation, obstructive sleep apnea, and then frenolectomy, a tongue tie release. That was the specific surgery that he had that kind of triggered some of these challenges. So when we saw him, he had just had that surgery in May. And right after that surgery, he drank out of a sippy cup. And I think, and Mark, you can help kind of clarify this too, but I think the family believed that it was painful for him to drink. And so after that, then he stopped drinking out of the sippy cup. And just a note that prior to the surgery, he was 100% independent, drinking out of the sippy cup. Luckily, he was able to continue eating, but he only wanted to play with sippy cups or any other type of cup. And so from a treatment or from a family perspective, they had tried a bunch of different things, including using different bottles, different cups, a plastic baggie with water in it, presenting a lot of really watered down applesauce or ice and yogurt. The most successful strategy was a smoothie that was mixed with Pedialyte and kind of frozen and kind of de-thawed a little bit and then fed to him by his parents. So when we started seeing him, he came in for a feeding TPS in DWP with myself and Kathy Krebs, the OT. He had a a swallow study completed and was cleared for treatment, and we started to do bi-weekly co-treat appointments with psych and OT, and we were really structuring the practice around drinking and getting him to even just tolerate cups and recognizing that cups were for drinking and not for playing, and then eventually for the oral increasing the oral intake. So this is a perfect like multidisciplinary case because we all had, different things that we were focused on. So for psychology, I was focused more on kind of the behavior management and kind of parent aspects of helping the parents and Rylan understand kind of the contingencies of what was going to happen. And then also with systematic desensitization, like we just talked about, of just getting him to tolerate cups and being able to not have a lot of disruptive behaviors around cups and refusing. And then from an OT perspective, Kathy was really focused on kind of the oral motor functioning and what were the best mechanisms for drinking. So were they cups? Were they bottles? Was it a straw? And then also from a sensory sensitivity, being able to manage some of those aspects. And then during this whole thing to like, poor buddy just had pretty frequent respiratory challenges and constipation. And so we were kind of working alongside that as well. So I just wanted to give kind of an update on kind of treatment. So we worked with the family for several months and he was able to kind of graduate from the psych and OT treatment where he was being compliant with drinking. And so then we needed to have speech kind of expertise to be able to increase the volume in a safe way. And so the care transferred from a psych OT co-treatment to a OT and speech co-treatment to focus on getting the volume of water or juice from a cup. And we have Mark here today, who is Ryland's dad, who I'm very happy to see, who can hopefully give us an update on how our little man is doing.
Well, yeah, it's been a long time since I've seen you.
I know. Yeah, it's good to see you.
So,
I know. I was thinking about it because he's 6 now.
yeah, he's 6.5.
Whoa.
Actually,
yeah.
he'll be 7 in June. He's actually drinking, we've got around 8 to 10 ounces of liquid from a cup now a day, which is a huge improvement from completely not drinking in the beginning. And yeah, so we got this, we went through probably 100 cups, different types of cups, but we found one that we really like and he really likes, and we leave it out. We have multiple of the same cups, and he's doing so much better.
I'm so thrilled to hear that, Mark. So awesome.
Sorry, this is my first Zoom meeting ever.
You're doing great. The fact that you were able to find the mute and unmute and get on here, that's impressive.
I have a whole paper wrote down and stuff, but it looks like you covered quite a bit of it.
We probably should have worked together on this. Sorry, Mark.
It was short notice. It's okay.
Yeah. So I think I'll give you kind of some background. And Marta, I don't know how much you've told Mark either kind of about our group. So this is our LEND cohort. They're from all different disciplines in developmental disabilities. And they come together to learn how to work from an interdisciplinary or multidisciplinary standpoint with our kids and families. And so that's who you have with us today. And so oftentimes the families will give perspective and then our folks will ask questions. So this is really informal. So whatever you think is important for them to know. And then also, Marta, I don't know if you have some specific questions kind of lined up that the trainees can ask.
Are you talking to me? I'm sorry.
So, Mark, from your perspective as a family, like we got Jen's kind of roll down of where you guys started. But like from your perspective of family, what were you guys going through? What was this experience like for you? I know it was many, many visits, which is one stressor. But where were you guys and how was it to carry this over at home? And what was it like when you got home and you were trying these strategies at home too?
In the beginning, the first week was pretty devastating for us. Him not drinking liquids, really, no one could really, it's like we kept running into the situation where no one really had ever dealt with this kind of situation before. So that wasn't good to hear. You know, our pediatrician said that if he's not drinking, we'll have to go maybe once a week to get an IV in him, which that was not good to hear either. But you know, we tried so many things with him, and we got on the smoothie idea. I'm not sure who brought it up, but we got to that, and that's how we had been getting liquids in him. You know, we had tried for months and months with so many different cups, and it took a long time and a lot of therapies. But you know, where we are now, I don't know if we would be in this situation if we didn't have our team with us, behind us.
And Mark, one of the things I was wondering too is, and you probably picked up on this like a little bit, but you know, knowing that like Kathy and I were working together and kind of focusing on different things. And then now, I think Kathy and Karen are working together and working on different things. Can you just talk about kind of like what that experience was like of having, you know, different providers kind of focused on different things, and yeah, just kind of like your perspective on it.
I mean, I think COVID kind of threw us for a loop with, you know, all the virtual stuff, but overall, each individual person we work with, we've been really impressed with. You know, we have individual stuff we're working on for each person, and it's really been helpful for us to focus on individual goals.
Trainees, what questions do you have? This is not their first Zoom meeting, Mark. They don't have an excuse.
I have a question. What did it look like before he made so much progress through feeding therapy? Like, what did meal times look like?
Feeding has not been the issue. When he was drinking, before he got his tongue tie clipped, he was drinking, you know, like any other typical kid. We had no worries at all. And then after he got his tongue tie clipped, it's like he took a drink when he got home, and I think it might have caused him some trauma. He threw his cup across the room, and that was the end of drinking.
Mark, do you remember the reason for clipping his tongue tie? I know sometimes, and maybe Hannah could give some more information about what a tongue tie is, because there's tongue ties and lip ties. But I think sometimes kids actually have the tongue tie released because they're having trouble with sucking, right? Do you remember why they chose to release his tongue tie?
Yeah, it was because she was worried. Our ENT was worried that it was a pretty bad tongue tie, and our ENT was worried that if, you know, when in the future when he started talking, it would hinder his speech.
Hannah, can you provide more information?
Yeah. So there are two different kinds. So like we said, there's a lip tie and a tongue tie. So lip tie is that little piece of skin between your lip, and it goes right by your middle teeth here. And then tongue tie is the same thing under the tongue. So right there, how the floor of your mouth is connecting to your tongue. So that can be a problem with the tongue, with feeding, getting that sucking pattern. It like restricts the tongue, and then also with speech, that's a great thing to bring up too, Mark. So I like to say with the L's, if you think about that, so that tongue tie is holding on to the tongue, that may restrict your tongue from getting all the way up. When you make a oh, you have to bring your tongue all the way up behind your teeth to make that sound. If your tongue is being held down by that tongue tie, you may not make it. So they may clip it in cases like that.
And Hannah, is it just that piece of tissue is shortened, or it's extended? Like, how does it hold the tongue down? Is it because everybody has a little bit of that connection?
Yeah, so different cases. It's hard to say like blanket statement on these, but a lot of times it's like a shorter piece there typically, but we can have some variations.
Thank you.
I'm curious, with your treatment process, like when was it that you felt like you started to make progress with the drinking, or was it certain techniques or practicing over time, doing stuff at home? I know sometimes it feels like we're doing the same things over and over with patients, and it takes a long time and people get frustrated. So I'm just kind of curious what that was like for you.
Oh, geez. I mean, we've been in therapy for, well, I think we took a short break, but it feels like 2-3 years. And we have tried so many different techniques. I think it was just the process of trial and error. And the team was just so thorough about it, and just being consistent.
Yeah, and Kate, I can follow up on that a little bit because in session, the way that we had our kind of practice set up is we would use a lot of visual supports. And Rylan is tricky too, because it seems like for him, like the novelty was always big. So he would be like really successful with something at first, and then kind of it would wear off, and then we would have to adapt and kind of change our approach a little bit to keep him kind of motivated and interested. But a lot of it was based on kind of like the gradual exposure to the cup, and actually like the physical kind of aspects of taking a drink and to have compliance, because we had those cups chucked across the room. Like, so a lot of it was building compliance around around that, and just like the tolerance. And like Mark said, we tried like a ton of different types of cups, and bottles and anything that you could think of. And it was that combination, I think, of the family being amazing and practicing it at home. And Rylan was also interesting in that oftentimes, Mark, I don't know if you remember this, like oftentimes his behavior was better at home doing the practice than it was in session with us. And we were like, that is cool. Like, if that is the way that we can make progress, that would be our preference, because usually we see it the opposite way. So just kind of giving the tools to the family, I think, to be able to do stuff at home made a big difference too, versus what we typically see.
Yeah, he definitely liked the audience of you guys.
And we played into that for sure.
Yeah.
If you saw him, if you met him, you would know.
Mark, you said he is drinking now. So what does it look like now when you offer him a drink? Are you having to use like the same kind of cup? Or are you able to expand on the cups? Like, what does it look like behaviorally too when you offer him a drink at this point?
Well, we use one cup now that seems to be working, and we leave it out for him. We actually have multiple ones that we leave out. But in our therapies now, we're working on the nosy cup with a little more thickened liquid, and just trying to get his lips around the cup edge to drink.
I was not familiar with the nosy cup, so I did just Google it.
Yeah, it's
an nose
interesting
fits in it. I get it.
Mm-hmm.
It's an interesting cup. So is it an open cup then?
It's an open cup, yep. And the problem with the open cups, if we give him an open cup, he thinks it's funny to spill it everywhere. So we do a very small amount of liquid.
I could see that happening. And then, so do you only have certain liquids you leave out in the cups, or?
We'll use juices, but we'll water it down. The problem with the cups we have now, the straws are they're a softer material, and he likes to chew them, and he'll chew the tops off. So we have to have quite a few extras available.
Sure.
Yeah, Marta, I'm glad that you said that about the cups, because that, for example, is one of the things that it's that whole idea of like staying in your lane and kind of recognizing like where your competence starts and ends. And I, like, as a psychologist, like I can work on several things, but like I didn't know like about the different types of cups and like what's most appropriate. And so like he's a perfect example, I think, of like different disciplines being able to rely on one another and say, okay, this is what I can do. I need help with all of this other stuff. You know, and how can we work together to do it?
I mean, we had a bag just dedicated to cups, and well, probably, I don't know, 50, 60 at one time in the bag.
How much do you think you've spent on cups?
Oh, that's, if I had to guess, I'd say probably $400 to $500.
Mhm. They're expensive.
Yes, they can be. The ones we have
Yeah.
now, I think they're called Zoomy cups. I think it's ZOOMI. I think they're like 9.
Yeah.
And we have like 4 or 5 of those.
Yeah. So you think about so many things here in terms of the successes your son has had. You all had the capability to bring him to therapy sessions, the ability and the desire to work with him at home, the resources to buy a ton of different types of cups and to problem solve with the team about how to make that happen. It's just phenomenal. But it also makes you wonder about, you know, the families that don't have the team we have here at their disposal, who don't have the additional funds, you know, and or the creativity to figure out what other cups are available on the market. Sometimes in therapy, we have quite a few. I know our OTs, I'm at the Mason campus, have a ton of different ones they can try in the clinic. But what a tremendous job. Do you feel like accessing services was easy for your family? Do you think there were challenges to that?
For us, I would say it was pretty easy for us. I think we just had so many resources before that told us, and so it was pretty easy for us.
Awesome.
And the team we have, we like I said before, I don't think we would be where we are now if it wasn't for them.
Mm-hmm. There was one question that popped up in the chat about whether or not he has needed any IV fluids.
Yeah, it was, I think, maybe 2 or 3 years ago. It was a snowstorm, and his labs came back pretty bad. I had to drive to Liberty Center Children's to get an IV, and I think we left around 2 in the morning.
Mm-hmm.
Yeah.
So he has blood work on a regular basis just to check his status.
Yes.
How often does that happen?
It's once a year.
Okay. Does he have any issues with, like, when you think about like hydration, dry skin, or are there any other like consequences that he deals with?
He has rough skin, and it's mainly in the winter.
Mm-hmm.
But you know, dehydration, that nothing has really come up with that yet.
Great.
But like he does, I mean, he eats what we call smoothies. You know, we showed him the sign for it. He learned the sign, and when he wants, if he's thirsty, he will sign that to us, and we have plenty. We always have plenty on hand.
Perfect. Very good. Any
We
other
did get one more
questions?
question. There's one more question in the chat in between my post about finding these cups. Is did you have to wait long to get into some of these services, especially co-treatment? We know around here, especially those co-treatment kind of visits in any area of the hospital, they're hard to get because we're aligning so many provider schedules. Did you have to wait a long time to access the services? And then were you maybe also already in some individual therapies during that time?
I'm sorry. I just read a question and I totally forgot your question.
That question was he on a wait list for especially the co-treatment sessions, because those are harder to access? Did you have to wait to get into the feeding program?
No, I don't feel like we had to wait long at all.
Okay.
Yeah, I think we kind of recognize the medical significance of this and got him in pretty quickly.
And then I'll read Kim's question next too. Did you experience any challenges with toileting because of the reduced fluid intake? Either, also I could also assume that it may not have helped the constipation concerns.
Yeah, well, he's on Miralax. But the thing is, we're still, we're in the middle of potty training. That's been a very rough spot. We're actually working with the county now. We were on a two-year wait list. We just got approved. So we have a social worker come in once a week. So what our pediatrician told us was just to make sure he had so many wet diapers a day. I think at that time it was like 3 wet diapers a day. And we just kind of kept pushing smoothies on him and trying to make it fun, to drink. We tried so many unorthodox things in the beginning of this. It was a very stressful time in our life.
We are so grateful for your time today, Mark, and putting, the family perspective in the forefront of our minds when we're thinking about serving patients and families that have issues with feeding. And thanks a bunch to Dr. Smith and to Hannah. And Hannah, I didn't recognize your last name. Hannah is a LEND graduate. And just wanted to point that out, that she's one of our LEND graduates working now in DDBP. And we're just so grateful for the information we've received today and how it might help us serve patients and families better. And again, Mark, thank you so much for your time today.
Thank you guys for having me.
Thank you, Mark. So good to see you all.
And now you're a Zoom pro, Mark.
That's right.
Well, thank you guys.
It's awesome. All right. So we have ITT team. Might have just sent it to me. Is it team 1 or 2 today? Team 1.
1.
Awesome. And why don't we what do you think about a 10-minute break, Marta? Go with that?
Yes, please.
Perfect. Awesome. So we're going to have a 10-minute break, and then those of you on team 2 can leave. And Hannah, thank you so much again for joining us. It's really lovely to see you, and you did an excellent job presenting, as did Dr. Smith. And we are we're glad that we were able to do that.
Well, thank you all for having me. Whenever you want me back, you just let me know and I'll clear my schedule for lunch.
That's awesome. That's awesome.
Thanks, Hannah.
Yeah, absolutely. Thank you. And then if there are any trainees too that want to reach out for any reason, so I was in LEND 2019 to 2020. We got cut a little bit short with COVID, but if anyone wants to reach out for any questions, especially the speech trainees, feel free to reach out via email and we can meet up.
Awesome. Thanks, Hannah.
Thanks.
Feel better, Jen?
Thank you. I'm gonna sign off, I think, Sally.